all the doctors present today, seniors, colleagues, and juniors. Thank you for joining us once again on the Tuesday Trivia, the monthly respiratory CME of the respiratory chapter, pulmonology chapter of the West Bengal Academy of Pediatrics. We generally try to bring in some very common topics which are relevant to your office practice. And today we have a very known, renowned name in the form of the panelists, and my job is like very easy. I had to do no homework because all of you are so well known that I don't need to introduce. They don't really need any introduction in West Bengal or even outside. So to start with, we have Dr. Gautam Ghosh, who is one of the pillars of pulmonology in West Bengal. In fact, when I came here around 1.5 decades back, he used to teach us so many ATMs and pulmonology clinics. And he's still a very ardent teacher, and he keeps on taking the DNB examinations all throughout India, and has a lot to play in the pulmonology chapter. The second panelist is Dr. Shubhashish Rai, and I think there's nobody in West Bengal who doesn't know him in the respiratory field, and he is my go-to person for any dilemmas in respiratory cases, and so many others also. And he's like so very well versed in chest X-rays and CT scans. So I think most of you are aware, and he's one of the another pillars in the respiratory chapter of West Bengal. Dr. Pallab Chatterjee, I think he's also no less famous, because he is the go-to person for bronchoscopies and also respiratory dilemmas. And throughout Bengal and India, he has been and I have not gone into their degrees and their respective, all the articles and publications, because that would take a lot of time. And last but not the least, Dr. Shomik Basu. He is a prolific speaker, as you all must have heard him in many sessions, and he is the treasurer of the West Bengal Academy of Pulmonology chapter, and he's also a member of the very active member of the medical legal chapter of the Indian Academy of Pediatrics. And today he is the moderator, and he calls himself the Sutradhar. And the topic today is a very common one, which is the bread and butter of all pediatricians. We thrive on these, and I think more so these days when we are having a huge deluge of viral cases, viral fevers and upper respiratory tract infection cases. So I think we can just start without any further delay. The cough and cold dilemmas. Dr. Shomik.
Good evening to you all, and thank you for giving me an opportunity just to present my slides. So this is the first time in history, probably all the panelists and the Sutradhar himself is from the same college, and all are seniors and juniors. I am being the junior most of all. And this is the first time in a pulmonology programs Tuesday Trivia, we have the best three as the panelists. So I am just a common pediatrician asking some questions, which questions were roaming about in my mind for a very long time, and nobody could give me these answers. So I prepared a set of questions most probably every pediatrician will have in his mind. And so I named the topic the cough and the cold dilemmas. So we'll go to the first slide. So my teachers in TMA spiritual diagnosis. So mane amar যা মনে হয়েছে আমি তাই দিয়েছি, আমি যা দেখেছি তাই দিয়েছি, জানিস তো এটা কাজে লাগে। So I took this slide from our Guru Paramahansadev, who said that joto mot toto pot. So as many there are opinions, there are ways to achieve it. So various doctors have various opinions about various medications, so they use various medications in various formulations for this simple two I would say one is a disease and one is a symptom, cough and cold. So the bread and butter of our practice is cough and cold along with fever. So I've asked the Amul girl to explain a little bit on these issues. So the Amul girl had said, yes, it is fair and square. It was fair and square few days ahead, where every doctor could give any medicine on earth and could be considered as fair. But the freedom of choice has unfortunately died after the CPA came into being, and the CPA is continuing to exist after the last verdict. So now whatever we give to our patient, we have to justify, we have to give evidence, or we have to give substantial proof as academic material or other proofs that we are justified in using these medications on the children that we are treating. So we would start with Subhashish Da. Subhashish Da, just a small question. What do you mean by cold?
Am I audible? Good evening, everybody.
Yes,
and
yes.
Thanks to the audience who have joined quite late in the night after the hectic day. Cold basically is a symptom which is signifies as the upper respiratory tract infection, and basically this is a viral infection. And it is an inflammation of the mucous membrane, basically of the nose, characterized by the runny nose, sneezing, itching, rhinorrhea, and some irritation in the throat and also in the eyes, with or without fever. Basically, this is a viral infection, and fever is most significant if the infection is by influenza virus, less by parainfluenza virus, and least by the other viruses like rhinovirus, adenovirus. They produce, of course, adenovirus can produce pharyngoconjunctival fever that produces quite a high temperature, but by and large, the fever is not so high, but the irritation and runny nose is the most predominant symptoms. And yes, what is reflected in the slide, rhinorrhea, nasal stuffiness, sneezing, it's a miserable life that the cold brings to a person or a child who is infected.
So cold is like the Aam Aadmi. It is very common in origin, but it does not cause much harm to anyone or causes any problem, long-term problems.
Except the influenza virus, none of these viruses like rhinovirus, coronavirus, and except few strains of adenovirus, none of them have any cytopathic effect on the respiratory tract. That's why long-term morbidity is less. Though the cough may be protracted for a few weeks, it can continue up to a few weeks, but the cytopathic effects are much less with the common cold viruses. So sloughing of the mucous membrane is much less common.
Thank you. So the common cold does not cause manifestation. When it turns, the same organism turns into cough and has invasive actions against the lung or something, so the morbidity increases. But common cold is usually innocuous in origin. So Pallabda, this bradykinin and lysyl bradykinin theory in cold, could you explain a little? What is the manifestation or molecular theory of cold? Is it related to any histamine pathway at all?
No, basically what happens is in cold there is a minimal amount of histamine release. So that is why when we use antihistaminics, it just gives some symptomatic relief, but it is not a typical treatment for cold. And another thing that I would like to say is, though these are innocuous, but actually having a rhinovirus infection, this year at least we are seeing a lot of patients who have this rhinoviral infection landing up with very, very severe infections and landing up even in the PICU. And a rhinoviral infection in a young child could be a harbinger of and could predispose this child to asthma later in life. So that is also something that we need to keep in mind. So though these are innocuous, but they can lead to problems later in life. That's number one. Number two, what I wanted to also add is, what I also wanted to add is, though we say it's a common cold and we think of viruses, but the allergic cold that is there, that also, like, normal patients and even doctors will many times confused with a viral infection. So allergic rhinitis and all these problems have a very similar presentation. Only thing that is not there is the fever and the symptoms in between. So that is also that we need to keep in mind and try to differentiate between a common cold and a allergic rhinitis.
Today we will not be talking about anything related to allergic rhinitis or allergic
Correct.
phenomena. We limit our discussion to common cold and cough only. So Ballabda has said what has said, the symptoms may be similar, but today we are talking only about common cold. And the other thing which I had to reflect, which I learned myself is, so just remember this is a bradykinin and a lysyl bradykinin theory behind cold. So use of antihistaminics are actually not justified because it does not manifest to the histamine pathway at all. The histamine is not released. So just keep in mind. So Pallabda, what are the available formulations for cold in the market?
See, available formulations, if you say that what are available are a few things that are locally acting. So like you can have these nasal drops where you have the saline nasal drops, starting from the saline nasal drops to the xylometazoline, oxymetazoline, and all these preparations that are there. And nasal sprays, like you have this azilastine and all these nasal sprays are there. Then there are various oral medications that are there. So there are medications, particularly the antihistaminics that are there that are used commonly for cold, and there are the drugs like the phenylephrine and all these that cause that are used for treatment of cold. And other than that, there are various other formulations that are like normal routinely people are using in the traditional this thing. But most of these medications are other than a few of them, the topical ones, the oral medications, majority of them are available as combinations, and most of these combinations are not correct combinations. So we have to be very, very careful when we use these combinations.
Vasishtha, we'll come to one by one what Pallabda has
Swami,
enumerated.
just may I come in for a minute? So far as the bradykinin is concerned, just consider our student days when there were few formulations like Actifed, Dristan. These were the tablets we used to use for common cold in our student days or in our adolescence. Now, those drugs are first generation antihistamines. If you can recollect, সেগুলো খেলে কিন্তু নাকের জল কমে যেত. But of late, presently, if we take the second generation antihistamines like fexofenadine or levocetrizine or loratadine, bilastine, all these things do not give any adequate benefit, as Pallav has elaborated that bradykinin is the potential cytokines for the features of the cold. Now, why the first generation antihistamines used to give a better result than the second generation antihistamine? There is a logic. The logic is that side effect of the first generation antihistamines has an anticholinergic effect. That's why first generation antihistamines, if you take, though it produces profound drowsiness, it reduces the runny nose part much faster than the second generation antihistamine, though it has no anti-bradykinin effect, but it has anticholinergic effect, which has a muscarinic receptor blockers are there. That's why it gives some benefit. Anyway, but it is not the medication.
We'll come to that. Everything is there. We'll come to that. So Subhasishda, one by one, very fast. So saline formulations. Are saline drugs drops the drug of choice? মানে এগুলো বললে সিনিয়র পিডিয়াট্রিশিয়ানরা মারবে, ইয়াঙ্গার পিডিয়াট্রিশিয়ানরা ভাববে পাগল, কিন্তু are saline drops the drug of choice for common?
Initially it clears the nostrils, it makes the path of the respiratory pathway clear, and it eases the effort of the breathing, especially in very young neonates or young children, and especially in infants. Now, they basically clear it has an irrigative effect. Basically, that is the thing, and it clears the debris, it clears the mucus, and that's the way it clears the pathway. That's the way it acts. It has no other. Pharmacological effect. Is there any fixed dose or upper limit of use? I do not know whether there is any other upper dose of use, but it is as close to the normal saline the strength, it acts better. Most of them are 0.64 or 0.75. These things are available. The market saline drops are available. Yeah, how long they can be given? They can be given as long as the symptoms persist. Side effects or contraindication, I precisely do not know. I do not know any side effect or contraindication. Any recommendation of hypertonic saline drops? No, not yet. Only the normal saline drop is good enough.
So what we have learned, it can definitely
nowadays we are having a few of these hypertonic saline sprays that are available, mist form.
But again, none of the studies have said any specific benefit if you are using hypertonic saline drops.
Yes, so it's only for these patients like
hypertonic saline.
Absolutely, yes. It's only for those class where you have cystic fibrosis and all
yes,
that. Otherwise,
yes.
normally no.
CCD or primary ciliary dyskinesia.
In my slides, the final recommendations that are given in form of block statements, this has come from a WHO guideline published long time back, and this is the only WHO guideline on cough and cold formulation. So they might change, but that RCT is a very good RCT. So they said that the Subhashis Das explains the method of action. So an easy way to administer normal saline drops, which is by moistening a wick in clean salted water and use it to drip. But these are European recommendation. They do not use much over-the-counter drugs, and some they have homemade formulations. And Mojada cheese is in our country, our Ayurvedic medications cannot be written by allopathic doctors, but in USA, if you see, they give Tylenol and they give Ayurvedic type of medications along with it for cough syrups.
And these saline nasal drops can be homemade. Take 2 cups of water and take 1 pinch of salt. That is equal to almost 0.75% saline. That can be given in the nose.
All of that. We come to the next and the most common
has joined. Shomik.
Gautam has joined. Gautam, then the next question is to you. Oxymetazoline, xylometazoline drops in common cold. Any role?
Hello. Am I audible?
Yes.
These are locally acting sympathomimetics, and they act as vasoconstrictor. This nasal mucous membrane in infant and children.
Gautam, ekটু জোরে.
The nasal mucous membrane in infant and children are semi-permeable. The use of these sympathomimetic constrictors, locally acting vasoconstrictors, are all symptomatic. They are not recommended at present in infancy, and if at all in childhood, not more than once or twice daily or more than 3 times. They act, onset of action is 20 minutes, peak of action is 2 to 3 hours duration of action, and hence the symptomatic nasal block, I tell you again, since are vasoconstrictors with a semi-permeable membrane, the nasal blocks are to some extent helped, but they are not anti-secretory like antihistaminics. Hence, this is only to remove the nasal block in a very difficult situation under the cover of guidance of the physician, and only not more than 3 to 4 times a day, because they have a lot of side effects.
So right. Gautam is absolutely right. In the foreign countries, they do not use at all. But in there is some evidence. I have looked up to the Nelson latest edition. What Gautam is saying, no use less than 1 year of age. if you use, it can be given maximum 3 times a day, not more than 3 days 3 days at a stretch. And if you
Right.
use money, the recommendation is if you use it once, it should not be used in that month again. So Pallab and Subhashis, I would ask your permission. So we can give once, or we can use, tell the patient to use saline drops from next onwards, or if they need more than 3 days.
I didn't get your
Yes,
question.
and
কি জিজ্ঞেস করছিস?
আমি বলছি যে ধরো আমি অক্সিমেটাজোন অক্সিমেটাজোলিন ড্রপ দিলাম, পেশেন্টকে আমি লিখে দিলাম 1 drop 3 times into 3 days maximum, and if you need further nasal drops you can continue with saline nasal drops, so that is
Yes.
okay na?
Yes, absolutely.
Or what you can do is, if the child is very irritable, advise that give this drop only at night time, but like as less as possible,
Yes,
and
yes.
not more than 2 to 3 days.
Pallab, have you seen
Just to
any
sleep.
case? Pallab, have you seen any case in your long career of rhinitis medicamentosa? Because I have yet to see a case of rhinitis medicamentosa in children, especially.
I have seen in adults, but not in children.
Yes,
But I have
absolutely.
definitely seen in adults.
I have seen many children, especially slightly grown up, typical history, মা এসে বলবে ডাক্তার বাবু অট্রিভিন না দিলে বাচ্চা রাতে ঘুমোয় না, গত
ঘুমায় না,
1
yes,
মাস
that
ধরে
is true.
অট্রিভিন দিচ্ছি। একদম ঠিক এই কথাটা এসে বলবে অট্রিভিন না দিলে বাচ্চা রাত্রিরে ঘুমোয় না, দ্যাট ইজ রাইনাইটিস মেডিকামেন্টোস।
হ্যাঁ, that is okay, but মানে আমিও দেখিনি সেরকম, মানে তুমি দেখেছো, very good. তো হ্যাঁ, Subhashis da, any other nasal formulations may be used, any role of these formulations in common cold like azilastine?
No, not at all.
So you were talking about
Ipratropium bromide may act, but it is not available as a nasal drop.
now this is a new wonder drug in allergy and other disorders. Can it be used in cold?
Not exactly. In cold, olopatadine has no use. Olopatadine can be used for a longer period of time in cases of allergic rhinitis, especially if it is associated with allergic rhinoconjunctivitis.
Yes.
It is a better drug for the eyes also.
Yes, yes.
Nasal steroid have no role so far as the common cold management is concerned.
Only there is a minor role of ipratropium bromide, but I don't think we don't
No, in
get
India
any
it is not
formulation like
available.
this,
No
but
ipratropium
in
dose is available.
this program we are not promoting any of these formulations for use in common cold.
But if and when it comes, ipratropium bromide, that is the one formulation that is available in the Western world, and that they do use it. So they
Yes.
have in
It
various
may help.
these
It
things
may
they have
help.
promoted that.
Gautam da, do common remedies work like humidification?
These are temporary supportive. There is no evidence that humidifying vapor inhalation, of course, what vapor inhalation is better than humidification from point of view of mode of action. Astringent, locally acting astringent, that relieves the I will again tell that these drugs, what you mentioned, yes, vapor inhalation, I don't know anything about herbal, but vapor inhalation out of these 4 choices is better because it acts as a local astringent. And again, I will focus there are 2 issues of rhinitis or of common cold. One is a sneeze, discharge, secretion, another is a block. They are usually anti-blockers, locally active, just evaporating the small amount of mucosal fluid or fluid above the mucosa and only making it patent. And again, you need multiple times. Regarding side effect, we don't have any idea, but we have seen that using vapor or using Vicks perinasally below the eyes, especially in infants, it helps a good sleep.
Okay, so if you can see the use of topical, acha Gautam da, menthol, camphor, eucalyptus oil, Vicks VapoRub.
Vicks is out of them good. Camphor is also. They all act as a. quick evaporator. The issue is these things have a very quick sublimation. That's physics. They have the very, in the room temperature, they go from liquid to gas. They take latent heat of evaporation and they make it cool. That's what is camphor, whatever you take. And the coolness is very soothing, sensitive in the nasal mucosa. Since the topic is cough, you remember the afferent cough reflexes are also in the nasal mucosa, mostly in the middle meatus. So that's
we
why.
are not
That's
so
why
we are not recommending anything other than some vapor inhalation, whichever might suit the child.
yes.
As highest. So we go to the next slide. So
Shamik, may I come in for a second? May I add a
in the
point?
chat box and question.
Yes, Shamik.
Yes.
Oh, just one point. It's a very common practice, same as that of Vicks, application of Vicks in the case that is Carval. Putting Carval plus in the water and taking the vapor out of it. But in my, I cannot quote any studies, but they severely dry the secretion and increases cough. So if you advise the parents to take any humidification or vapor inhalation, ask the parents to use only plain steam. Don't add any other things like Carval or Vicks or like these things. It may give immediate relief, but it will increase the cough immediately next day or after that. So it is better to avoid them.
So they might.
And there have been a lot of burns using steam, so we have to be very careful.
There are a lot of burns in the steam, so you should be very careful giving steam inhalation, even in cases of croup also.
Yes, correct. So we go to the next one, oral medications for cold. Pallabda, can they be used for common cold? Oral medications for cold?
See, basically, if an immediate relief is required, people do use all these medications, but it's better to avoid because we know that these are all self-limiting. So only topical medications like our saline nasal drops are good enough. And other than using these, like, phenylephrine and chlorpheniramine maleate and all these drugs that are there, it can cause more harm than good, and it can dry up the secretions, and later on it can lead to acute otitis media and all the other problems. So it's better to avoid. If required, maybe given only for maybe 1 or 2 days, because we all know that common cold is a self-limiting condition. No point in giving these medications.
Gautam and Subhashis, any comments?
Only thing I can say only one thing, that is, first of all, first generation, all this combination comes with the first generation antihistamines, chlorpheniramine maleate with phenylephrine or phenylpropanolamine, which are sympathomimetics, non-selective sympathetic adrenergic receptor stimulant. Now, problem is that the chlorpheniramine maleate first generation antihistamines are not recommended below the age of 2 years. But off level, all of us use. There is no doubt about it. But be very careful so far as the infants use in infancy. They produces profound drowsiness in the children. So recommended, don't exceed the recommended dose. That is the only thing. And if you use what Pallav has said, use just for 2 days or 3 days. As soon as the runny nose and stuffy nose part is over, as soon as the child has started coughing, immediately you stop it. But please remember, it produces profound drowsiness, which is very bad for young neonates and for the children who are below 6 months.
My only take on message to the pediatrician will be avoid as much as medications for cough and cold as possible, because the parents take these medications as just home remedies. সর্দি কাশির ওষুধ দিয়েছে মানে ডাক্তারবাবু দিয়েছে, একবার লিখেছে মানে আমি 14 বছর অবধি যতবার চেষ্টা করব, যতবার কিছু হবে আমি খাওয়াবো। কমনেস্ট হচ্ছে যে ডাক্তারবাবু সর্দি কাশি হয়েছিল, আমি 2 দিন আপনার 4-5 দিন আপনার ওষুধটা খাইয়ে এসেছি, তারপরেও কমছে না, সেই জন্য আপনাকে পয়সা দিয়ে দেখাতে এসেছি। So if you stop the practice of writing cough and cold medications on every demand of parents, this overusage or overdosage of cough and cold medications will also decrease. So we go to the next slide. Gautam, the antihistaminics we know. So do you recommend antihistaminics below 1 year, or when should we use antihistaminics if we ever decide to use?
There are two questions in this group. If age group is first, if the age group below 1 year, the anticholinergic effect of the first generation antihistaminics are usually experienced in the infants, and this is not indicated because there are more side effects. More than in infancy, the use of a second generation antihistaminic, if you really need to use it as an anti-secretory drug, is minimum side effect. Recommendation goes in favor of second generation antihistaminics. And again, the duration, what do they act? They usually act against the histamine or the histamine-like substances that is released due to inflammation, I would rather say. It is not always infection. And they are affected temporarily, as Pallab and Subhasis said. 48 to 72 hours are usually recommended. And if, only if, and only if the symptoms are unbearable and we cannot counsel the parents and the child, it is a fault from our side to alleviate. Don't use it. Regarding the third generation drugs, again, these are newer drugs. They are also not recommended below 1 year or 2 years mostly. And they are also good. You can choose your own. It depends on choice. Of course, you remember the side effects. The two issues I will say before I finish is very difficult to choose an antihistaminic below 1 year of age until unless required. And number two, always remember the side effects. And there are preparation of combination of antihistaminics with specially leukotriene antagonists. These are at this point of time is not recommended because their onset of action, duration of action, and the total days to be used are quite different, right?
So Gautam, is there any toxic dose for antihistaminics?
It depends on the drug. But there is nothing. There are a few antihistaminics. Of course, I just can't remember this pharmacokinetics, which are can produce really toxicity. The commonest is the drowsiness, but the recommended pharmacological dose will not produce toxicity.
I would ask the practical aspects to both Subhasis and Pallab. So doctor refusing oral medications for cold, even after insistence by patients. How important is parent counseling?
That is the crux of the matter. That is the crux of the matter, because you have to tell them that this is not required. Like we had a lot of problems, we still have a lot of problems counseling patients regarding use of inhalers. So similarly, this also needs a lot of mindset, a change of mindset among doctors first, and then amongst patients and the lay public at large, that these are medications that are usually not required and will not be given. But if we have to write something, it is always better to write an antihistaminic, maybe a second generation antihistaminic, though we know very well that it's not going to work that much. But still, it is at least recommended, and no one can point a finger at you that you have written a drug which should not have been written and this child landed up in some problems.
Yes, absolutely. But Shamik, one interesting part of the toxic dose is that these antihistamines are very well tolerated by the body, even 10 to 20 times than the therapeutic dose exceeding 10 times of the therapeutic dose may not produce any severe side effects in the body
Yes.
except drowsiness.
So I went through literature and we have found that paracetamol is the safest one. The toxic dose is 200 times the normal dose. For antihistaminics, the toxic dose, as Subhashis is saying, is actually 30 times the normal dose. So even if you give 10 times, so it will not cause that much amount of toxicity as we are talking about.
But we are
But
not
the-
advising to give 10 times.
Paracetamol 200 times, Suna?
Yes, 200 times.
200 times, Suna. Paracetamol, it is 40 times, but not 200.
200. Let us so our key message to the pediatricians listening to this lecture is do not write antihistaminics less than 1 year of age at all. If you use antihistaminics above 1 year of age, as Pallab had said, you use a second generation or a third generation one as per recommendation, as per dose, and limit yourself to 3 days. You do not extend it beyond 3 days. Am I right, Pallab?
Yes, definitely. 3 to 5 days max, but not beyond 3 days, preferably.
So these are the toxic effects of antihistaminics we rarely see. I don't know if, even if you see, but the commonest thing I see is people, children who are getting repeated antihistaminics are actually hyperactive children. So every hyperactive children, please ask the history of administration of antihistaminics over a long period of time. So what is the, am I right?
Can I come in? Hello.
Yes,
please.
Gautam, please.
I have a holistic idea. Why this child is getting recurrent antihistaminics? Have a holistic view. You'll find they are mostly allergic rhinitis.
Absolutely.
And if you know, attention deficit hyperactivity disorders and allergic rhinitis are closely associated genetic disease. So I think that's the answer. Okay, please proceed.
Thank you, Gautam. So, Gautam, this is the best question to ask you. What is cough?
I have to go for pharmacology. It's a physiologically, this is a
Gautam
protective. Physiologically, this is a protective reflex. Expiratory effort from the middle and the lower airway, which expels out in a velocity which is many times more than the velocity of normal breathing, to forcibly bring out or throw away the miscreants from pollutants to foreign bodies, whatever it is. And it is a simple protective reflex. And to be pharmacologically answering cough has a reflex. That's why the drug goes. It has an receptor from nose to even GI tract. It has an afferent node, which is mostly cholinergic. It has a center, which is just below, I think, between pons and medulla, and which is also controlled voluntarily. Cough is an involuntary reflex, but can be voluntarily controlled, just like your bladder. And there is an efferent pathway, that's again by cholinergic, which goes and have targets on intercostal muscles, accessory muscles of the chest, diaphragm, and so many others. So that's usually the physiology.
Is coughing good?
Always. See, if a newborn should cry and a child should cough, that shows the parents, doctors are happy. That's always a good idea to cough. Basically, it's a healthy reflex.
So when should you actually treat a cough? As a pediatrician, when should you treat a cough? If cough is good, when should I treat it?
I would rather, everyone here will treat the cause of the cough, not the cough. Everyone here will treat the cause of the fever, not the fever. But your point is well taken. You have many times you have to use paracetamol or antipyretics to reduce fever. Similarly, only in very distressing condition, you should give it to reduce the cough. And there are straight away two options. Option one, If the cause of the cough is a bronchoconstriction or airway, you treat the bronchoconstriction and that will bring down the cough. And the option 2, which is very, very difficult, if the cough comes from the upper, cough is a disease of the airway. Cough is a disease of the airway, not in the parenchyma, not in the pleura. If it is in the upper airway, it is a non-productive cough for any reason, from habit cough down to pressure from SOL. And distressing very much, disturbing the sleep of the child and activity in the school. If it is not habit cough, you should definitely consider temporary, just like antihistaminic, temporary cough depressants, only on temporary basis. So these are
Gautam
the
da,
yes.
Gautam da, for a common pediatrician, should we make any difference between dry and wet cough and treat differently? এই যে মা এসে বললো ঘর ঘরে কাশছে আর আরেকটা মা এসে বললো শুকনো কাশছে, এটা কি ক্লিনিক্যালি কোনো সিগনিফিকেন্স আছে আর ট্রিটমেন্ট কি চেঞ্জ হচ্ছে কিছু?
The answer is very simple. Parents or caregiver will say same, but don't ignore them. Remember whatever the parents said, listen carefully. Jodi ma moist, if the mother has said this is sometimes moist cough, and you on auscultation you don't find any other crepitations or wheezing or any other signs of moist cough, don't ignore the mother. You have to find out the cause of the cough. The question you put, should you distinguish dry cough and wet cough from the parents? Yes, we must keep a suspicion. We keep parents in faith, number one. Then we find out the cause of the cough. Remember, the cough which is dry on Monday may be wet on Thursday. And similarly, the other way around. And you treat, again, I tell you, not the dry or moist cough. You treat the cause of the cough. And you know, dry cough reasons and moist cough reasons are quite different. We have to follow them up, clinically examine when he is coughing, when he is asymptomatic, and many times we can find out the cause.
Thank you so much. Excellently explained.
আমি একটা ওয়েট এন্ড ড্রাই কাফের ডিফারেন্সিয়েটিং পয়েন্ট বলবো।
হ্যাঁ বলো।
In a Hindi film, the actress who is drenched in
একটা ছবি ছিল কিন্তু আমি লজ্জায় দিতে পারিনি সেটা, মানে
একটা মাসালা মুম্বাইয়ের ফিল্মে একজন হিরোইন যে drenched in the rain ডান্স করছে, আরেকজন হিরোইন not wet, dry ডান্স করছে, to whom we will look more carefully, the heroine who is wet. So wet cough is always sinister. Wet cough, you should give more time to examine the child with a more meticulously, because persistent wet cough may signify more sinister diseases like bronchiectasis, tuberculosis, or primary ciliary dyskinesia, or many other things, or persistent bacterial bronchitis. So wet cough is always sinister. And second one trivia is that when we cough, the velocity of the air that comes out from the lung may exceed the velocity of Rajdhani Express. It may exceed 100 miles per hour. So cough, though protective, sometimes it may be very difficult for the parents to tolerate. So sometimes we may require some medication to reduce the cough, but most of the cases, as Gautam said, it is always better to treat the cause than the symptom itself. Thank you.
One specific condition where we really need to treat the cough is pertussis.
Yes.
If you have a child with pertussis, you have to really treat that cough and get it down.
But Gautam, does any cough suppression really work in pertussis?
The issue is straight away. Why do the child cough in pertussis? Cough, as we all know, is an airway disorder. What happens in pertussis? Lymphocytic infiltration of the submucosa throughout the airway. Once it starts, it is an irreversible process. The answer to your question in a single point is no. It's only the frequency may reduce, because I again tell you, give you the correct answer. What is the afferent stimulus? The airway. What is the center? The cord, medulla and the cord. What is the efferent? Back. And what is the to the muscles? But I told you again, just like bladder, there is a voluntary control of the cough center. If you can use this, especially difficult in children, but you can use these episodes of cough, presentation of cough comes down, but the inflammation does not come down. I will add only 2 points. How can you reduce or have a what you call voluntary control of an involuntary cough center is by sedation. And the most of the drugs, except dextromethorphan and the probably peripherally acting, what is that called, levocetirizine, most of these drugs are usually CNS sedatives. Previously, morphine was used, codeine was used. That reduces that depresses the medullary center as a voluntary control. That's that. The only issue, I'll finish with the last line. If you want to treat pertussis, you treat the pertussis organ bacteria by giving a correct antibiotic in the first 7 to 8 days of life. That is the way that it doesn't proceed. When it goes after 2 weeks, 10 days, even if you give an anti-pertussis drug, the cough does not subside. And previously, we called him a 100 days cough or 3 months cough. So what is our objective now? To reduce, make it, the child sleep and have a good voluntary control of the involuntary centers.
But Gautam, in pertussis, we may require cough suppressant in some cases. And another thing is that in upper respiratory infection or in viral infection, asking the parents to take twice the amount of required fluid every day will to some extent reduce the severity of the cough. অনেকটা জল খেলে কাশির ইন্টেন্সিটি কমে, there are evidences for it. And this is a very
জ্বরেও
simple,
কাজ করে, জ্বরের মধ্যেও যদি ভালো
yes,
হাইড্রেশন
it
মেইনটেইন
definitely
করে
gives a relief to
টক্সিসিটিটা
the
কমে
children.
যায়।
Right.
So I must say that I am very grateful to Dr. Subhashish Roy. Some of his slides are incorporated in my slides, so it has made my work much easier. So we are not going into the Gautam that has explained beautifully. So only thing is, Subhashish, the ek line jodi bolo, why do children cough in cold?
The threshold for cough is reduced. The cough reflects the receptors, the threshold is reduced, and that's why the children cough basically. This is the basic reason. And apart from that, there is an irritation in the upper airway, shedding of the mucosa, epithelial membranes, and blocking of the respiratory tract. But cough comes only mostly from the airways, nothing from the alveoli, and to some extent from the pleura. But it is basically lowering the threshold of cough from the receptors is a basic cause for cough in the upper respiratory tract infection or viral infection.
So we finished up with cold, we are going into cough, and this film, I think nobody should miss. Even the younger generation or our generation should come off their mobiles and watch this film, the good, the bad, and the ugly. Why have I put this slide? We'll come to that later, because now we come to the syrup formulations, and Subhashish, there is an excellent slide which will show, and we'll find out whether there is any good cough syrup, a bad cough syrup, and which are the ugly ones. So if you can see, this is taken from the net. So there is a variety, more varieties will come. So there is no limitation and brand names and types and formulations of cough syrups. So let us try to say, Pallabda, we'll start with you. So is single combination the good one?
See, one thing I would like to say is any disease which has got a large number of treatment, that means nobody knows what is the correct treatment.
Correct.
Otherwise, nobody would have had so many. So every disease should have one treatment. So similarly, cough is this thing that's a very common symptom, but there are so many varieties of treatments. And as you said, any medication should always be given as a single medication, cannot be combination, but it is a single medication. So that is always good, and we should avoid combinations at all costs unless something which is actually worked out, like coamoxiclav, or you want to give trimethoprim sulfamethoxazole, so something like that. Otherwise, do not use any combinations for anything. Now, single drugs, if you say that, yes, maybe one antihistaminic, if you want to use, you can use dextromethorphan. If you really want to use, you can use levocloperazine. If you want to use, you can. So these are a few drugs that may be used for cough. And if you are really thinking of a bronchoconstriction, then you might use a salbutamol preparation for that. Otherwise, I don't think we should use any a drug which is for cough.
This was a specific question of mine. Dharo, a child has come with 3 days of fever and you auscultate the chest, the child has wheeze. So it is a typical virus-induced wheeze first episode. We'll take it like that. Can we use cough syrups like salbutamol or levosalbutamol, purely cough syrups for the first time? Or should
Yes,
we go
definitely.
to inhalers? We don't need inhalers for the first episode?
No, not necessarily. It depends on how the child has presented to you. If the child is a very young child, then maybe I will go for inhalers. If the child is an older child, then probably I will. And the first episode, child is otherwise well preserved, then oral medication we can try. Now, if we see that the child is quite sick, and we may need to that only once or twice a day, or maybe 3 times a day, this medicine is not going to work, we might need it more frequently, then it is always safer to go into inhalers at the outset only.
So
So it
Gautam, can
depends
we
on the
say
clinical presentation. But if this child is coming to me very frequently, then definitely I will not go on prescribing oral medications every time, and I would definitely shift to inhalers.
So Gautam, can we say we see 3 episodes and treat with oral medications if the child is coming in me to me at intervals of 3 or 4 months, and if we see that the episodes are getting more than 3 in a year, then we shift to inhalers? Is that a safer approach, or we start inhalers early?
The issue is, what is my diagnosis? The diagnosis,
আমরা যেটাকে বলছিলাম এপিসোডিক ভাইরাল ভিজি আমার ডায়াগনোসিস, কিন্তু less than 3 times হলো, can we use syrups or we go to inhalers from the second episode or third episode?
the issue is very straightforward. You are giving an example of an infant or a toddler, right?
Yes, toddler.
Okay, make it a toddler. So this is below 6 years. And he is presenting with either a episodic viral wheeze or a multi-trigger wheeze, which so unmistakable. The question is oral versus inhaled bronchodilator, right? Short-acting
Yes.
bronchodilator.
Yes.
There are two answers. There's two points. Why does the inhaled bronchodilators acts faster? Peak of action is same, duration of action is same, onset of action is faster because it goes directly. The second point is, this is probably have a minimal side effect. These two are advantage of inhaled SABA versus an oral SABA combination. Now the answer is straightforward. Option 1. If we think it is only episodic viral wheeze or may not be like this, we can use an oral bronchodilator, which is only for a couple of, or 1 or 2 or 3 occasions, and we're suspecting it is not going to be a multi-trigger or an episodic viral wheeze, which are interchangeable. If we, so we can use oral, because even if the onset of action is late, but this is only 1 or 2 occasions. But if we suspect it is a episodic viral wheeze or multi-trigger wheeze, if we suspect, or it is really an asthma, for example, then oral inhaled drug is better than oral drug, and that is in GINA 2022.
Yes.
Thank you.
Subhash is the rapid fire. When do you use bronchodilators alone?
Before that, there is a question in the chat box. Can I take the question?
Yes, yes, yes,
There
absolutely.
is a question in the chat box that guaifenesin should be used or not. Now, answering that question will solve many of the problems in this slide. There are 4 types of things that are available, which are used with the cough combinations. One is your expectorant, that is guaifenesin. Second is your mucolytic, that is N-acetylcysteine. Third is your mucokinetic, that is ambroxol. And there is another category of drug, which is like Dornase alpha, that is a mucoregulators. Now these things, they are also the anticholinergic agents. Guaifenesin and bromhexin falls in the group of expectorants. How they work? They pour water inside the respiratory passage, then liquefies the mucus, and so that the expectoration is better. So whenever you combine guaifenesin with a bronchodilator, that means you are using in a condition when already the respiratory passage is compromised. It is already narrowed down. So pouring more water in a compromised airway will reduce the caliber of the airway even more. Of these 4 class of drugs, that is mucoactive drugs, expectorant, mucolytics, mucokinetics, and mucoregulators, none of them should be used in respiratory tract common cold infection. Not even for a child who is having a ghore kashi after brief period of initial upper respiratory tract infection, they do not help. Rather, they produce more problem than help. So if you want to use bronchodilator, use single molecule bronchodilator. Do not use bromhexin, it increases vomiting. Do not use guaifenesin, it will increase the cough. Ambroxol increases the ciliary beating, and that's why it helps in propelling the mucus upward. But do we have any problem in ciliary beating in upper respiratory tract infection? No, we don't have. So don't use any combination. If you are using bronchodilator, use bronchodilator only. Any other question, Shomik?
Now you have that question helped us because we had this slide ready, so we are going forward. Side effects. So this is the last slide. So there have been recent episodes of deaths due to dextromethorphan. Pallab da, Subhashis da, Gautam da, I need all your inputs. Why are we so worried about dextromethorphan, and what is so deadly about dextromethorphan? Is it the drug itself or some combination used which we are not using it properly?
Basically, that is what happens. No, the drug that is available as a cough suppressant is never available as a single molecule usually, and we tend to give it with other combinations also. And the other thing is that once we give it and the patient has been like, they, as you said initially, that once you write a prescription, they will go on taking that medicine on their own over the counter. So all these things can lead to a accumulation, and these side effects can occur. So that is a major issue with all these cough syrups, because one combination can cause more problems.
Yes.
Are we worried about dextromethorphan?
No, dextromethorphan produces a severe syndrome. I do not remember the combination drugs. I think it is linezolid with dextromethorphan and probably erythromycin with dextromethorphan. They produce a syndromic problem, and that is quite catastrophic. That's why we should be careful about the dextromethorphan, and dextromethorphan is also a morphine derivative. One very important point, so far as the cough suppressants are concerned, there are 2 types of cough suppressant which has a very close similarity in their name. One is levodopa and the other is levocloperazine. Now, levodopa acts on the C fiber, afferent fiber, and it is not a morphine derivative. But be careful if you are using levocloperazine, which is plenty available, like Zerota,
brand name গুলো বলে দিলে লোকজনের একটু সুবিধা হবে।
Rhinitis is the only formulation available which is levodopa, which acts on the afferent fiber, non-sedating, non-toxic. You can use below 2 years. But levocloperazine are morphine derivative and frequently produces drowsiness, and be very careful so far as the dosage is concerned. And I do not remember the syndrome's name, but dextromethorphan, when used with some other medication like linezolid or erythromycin, it can produce
serotonin syndrome, So there is
Yes.
a Hunter criteria. I have given this slide, and though it does not cause anything with azithral, but remember this drug was not used by pediatricians or other specialists for 10 years ago. This linezolid has become an over-the-counter drug almost, and orthopedicians use it left and right like anything. So be very careful. Somebody is getting linezolid from some other doctor, and you prescribe dextromethorphan on top of that, and linezolid is deadly. Linezolid dextromethorphan is deadly for this, causing this serotoninogenic syndrome, and this can cause death in children. Gautam, your special inputs. This was the last slide.
I think the best cough suppressant are the throat lozenges.
বাহ, আজকে খুব ভালো হচ্ছে, মানে যা বলছো পরের স্লাইডটা তাই তৈরি আছে। হ্যাঁ, কন্টিনিউ প্লিজ, কন্টিনিউ।
Because I told you the cough is a reflex pathway. Receptor, afferent, center governed by the voluntary system, efferent, and muscles. And the most sensitive part is the receptor. And if we consider inflammation or infection as the cause of the airway cough, the receptors, as Subhasish and Pallav had many times told, the receptors, the mucous membrane, the ciliated, the cuboidal, mostly ciliated, they are paralyzed. In fact, the basic issue, if you go in, they have a sodium, potassium, calcium channel, and that is blocked. They become hypersensitive or hyper-reactive. rege jawa bachchar moto. And if you can anesthetize them, I'll report, if you can anesthetize these areas, this is the best method to reduce the cough. But I will stop, finish in the same breath. Remember, in an infant, in a children, the airway hypersensitivity is very useful because they will prevent the undue common refluxes, because GI tract and the trachea are so close, and the valves and the muscles and the cartilages are not working. So that is the caveat. Thank you.
So thank you very much. So these are the take-home messages. I will not repeat them, but what I give you is a nursery rhyme or a rhyme-like phenomena, which is explained beautifully.
But there are some questions also. Okay, can you take
now?
yeah.
Now take the questions.
Yeah. So there was this question by Dr. Manglik. Do saline drops contain benzalkonium? Saline
Yes, they
drops.
do, and yes,
Yeah.
they are used as a preservative. So
Yeah.
that is why, like we have an idea that you can go on using it as much as possible, but usually the amount that is there does not cause a lot of problems when you use it as a topical medication.
Okay. So Dr. Alok Pal has asked, what is an ideal expectorant?
Plenty of water, plenty of water.
And humidification maybe.
Yes.
Humidification, the mist chambers are recommended, or
Yes. And it is now a very easy and very nice mist. Now the one that has come out, saline mist, is quite nice.
So the equipment which they have brought, yeah, the small machine.
Mm-hmm.
Acha, have you used, Pallav, have you used the mist chamber? I have never used it. Does it help really?
No, it is by the same company, and it comes as like a spray, where they have a setup, a set on the top, which you turn and it will go on spraying, and once you turn, it goes on spraying for a minute, and then and in between you can turn and stop it. So if an older child can hold it in the mouth, there is a mask which you can put on the face, and it's a very soothing sort of a spray that comes out. So it's a way of humidification, and patients will have something to do actually, sit and do and call less on the mobile. So that is a way of
Cost of therapy.
managing cough.
And what about mucus extractors like those bulb syringes which they use?
Yes, that you can use to clear the nose, no? So if you have a cold, so that is one thing very good, and we can use it to clear the nose. I think there is a question saying that what is an ideal expectorant?
So
So I
that
think we
was
discussed
answered in
that.
this water. Yeah.
Yes. So are we waiting for dinner to be served in our
Swiggy.
conference?
Yeah, Shubhashish is sending from ITC, Royal Bengal.
You slip or
Shomik, you can show the poem which you wanted to show.
I'm just
This one, 5 nasty germs were going out to play. Along came the water and washed one away. So Subhash is the water theory. 4 nasty germs trying to have some fun. Along came the soap and one had to run. Hand hygiene. Then 3 nasty germs tried to make you sick, but along came the scrubbing and said you're not going to stick. 2 nasty germs got into a fight. Along came the rinse and washed one off sight. 1 nasty germ thought it couldn't be seen. Along came a towel and your hand was nice and clean. So hand hygiene and everything explained in a beautiful poem. Hope we learned. We never learned. After 2.5 years of corona, we still have not learned how to wear a mask, how to wash our hands, how to use a sanitizer, and keep away from the crowd. Hope we learn one day, and that day, most probably pediatricians will be deprived of half of their practice. So I would not live to that day, but it was an excellent program, very well explained, and it was a beautiful program, one of the best I have attended. Thank you so much, the panelists. Thank you so much.
But Shramik has done a splendid job. Very good moderation.
Yes, perfect. Thank you.
Perfect.
Thank you very much.